Well, we're here. It's Healthcare Unfiltered, and we're doing a GU episode because we got to know what's going on in ASCO 2024 in GU. And literally, I interrupted Petros as he was saying, tell me about Rana.
I was saying very, enthusiastically that Rana is our inspiration. She's fantastic, not only scientifically, of course, and her leadership, but also, her amazing physical exercise activities is really inspiring us to do better scientifically and also exercise-wise.
Petros, that's partly, I don't know if you know this, but partly there's a Lebanese heritage in Rana, and I don't know, maybe there should be a Lebanese in you, man.
I can say Lebanese and Greeks are very close. They're geographically, right? They're Mediterranean. So Mediterranean diet, energy, all together.
So
right?
I was telling Chaddy that the next book is coming out, and I don't know how he can write books. I can barely keep up with the manuscripts, let alone writing a book. So that's phenomenal.
Your manuscripts are way more influential than my books, but you can tell if folks are listening or watching, you can tell that this is going to be some fun exchange. And quick intros, by the way. Rana, maybe a bit about you.
Sure. I'm a genitourinary medical oncologist. I'm at the University of California in San Diego, and it's a fantastic place, really kind of booming, which is awesome. I lead our GU group and help spearhead our clinical trials and clinical research at UCSD. So it's been fantastic.
And Petros.
I will follow the theme of fantastic, as my good friend Rana mentioned. I'm at the University of Washington Fred Hutchinson Cancer Center. I'm a professor here in the Department of Medicine, Division of Hematology Oncology. I'm serving a wonderful group as the clinical director of the GU Cancers program. And I can tell you, I learn from my colleagues every day. It's amazing to be here. And I would say Seattle is a wonderful place to be. And more importantly, we have Greek weather. So I invite both of you to come and join me.
Yeah, and we're tipping this for ASCO 2024 and between ASCO and ESMO. Rana, do you know what my dream is for ASCO 2024? Like I was thinking, no, for ASCO in general, I was thinking like, what would I want to accomplish in ASCO 2025? And there's like one thing I would like to be able to get done. Do you want to know which one is that?
In next year's ASCO.
Like next year's ASCO, because this ASCO is gone, but there's like one thing I would like to be able to accomplish next ASCO.
I don't know.
I want to be able to be invited to the Greek dinner that Dr. Petros Grivas always has, and somehow I think he sends me the invite. It just gets lost in the mail somewhere. But I believe like I'm going to put the U.S. Post Office. I'm going to tell them to expect something for next ASCO 2025.
I'm sure your dreams have come true, because I'm sure that the invitation will be extended.
Well, it's on the air right now. I mean, if I don't get invited, there's a big problem, either in me or in Petros.
This is being recorded. Rana is our witness. You're invited, my friend, to the legendary Greek dinner. This year was the 10th year tradition. I think we broke all records. We have more than 70 people there. And of course, I would love to see both of you next year. I would love to share with you, the hospitality, the tradition, the food, and of course, to prove to my good friend Sadi that baklava, the best baklava is Greek.
Hey, if I get invited to that dinner, I'm in, man. So what we actually decided to do is we're going to do like a quick thing about just get people to know what they may have missed at ASCO 2024, some of the top abstracts. I think thoracic oncology took the glory in ASCO 2024, and I aired, I taped an episode on that, but GU will not be forgotten. So it could be 2 abstracts, could be 10 abstracts, could be 5. There's no limit, but the idea is things that caught your attention or eyes that may be clinically relevant. And of course, you both probably are authors, co-authors, primary authors, senior authors on a lot of these abstracts and papers. So I'm always humbled being in your company. Rana, you want to get us started with one that you talk about?
I will get us started. I'm more than happy to speak. I think probably one of the most exciting abstracts for me at the meeting was one of the kidney cancer abstracts actually looking at the prognostic and potentially predictive significance of KIM-1. So KIM-1 is kidney injury molecule 1. It's basically a membrane glycoprotein. It's been used as a marker to assess recurrence risk and DFS and OS. It was actually tested in the ASSURE trial, also tested in CheckMate, a study of Nivo-Ipi. And it's a blood-based biomarker, which is really excellent when you're assessing recurrence risk. It can be done in real time, very temporally, like in a temporal relation to when you actually need to make an assessment around what you're going to do. Now, the Emotion 010 trial, just to kind of level set for individuals, this was a trial that looked at atezolizumab versus placebo for patients with resected RCC that was at high risk of recurrence post-nephrectomy. The trial itself had a primary endpoint of DFS, and the trial did not meet its primary endpoint. It was a negative study. And so this is a biomarker assessment from the Emotion 010 study. And what was determined from this trial is actually KIM-1 was prognostic of DFS. The KIM-1 high individuals had worse DFS compared to the KIM-1 low individuals. And what was really quite interesting was that if you actually looked at how the KIM-1 high patients did with atezolizumab versus placebo in the high subgroup, it actually seemed to be predictive of response to atezolizumab, with a median DFS that was not reached in the atezo group for the KIM-1 high subgroup, where it was 21 months in the placebo group. Now, when you looked at DFS in the KIM-1 low subgroup, there was really no difference between placebo or atezolizumab. So I think this was really quite interesting to, that this marker could potentially be prognostic and predictive. And I think this is something that we struggle with in clinical practice. We struggle in clinical practice, like, who do we give adjuvant therapy to? Right now, we mainly have clinical parameters. We know we undertreat some. We know we overtreat some. How can we get it just right? And maybe this is a marker that can help us get there.
So, Rana, a couple of cool questions, and I'll have Petros react to this. Number one, how often you see KIM-1? What's the, is this like always there? Like, what's the percent?
So that's a good question. I mean, this is a soluble biomarker, and they actually did an assessment on the threshold percentage to utilize as the cutoff for determining high and low subgroups. This was presented in the publication or in the presentation, and they actually determined that a threshold of KIM-1 levels kind of greater than 60% of the quartile was that 86 picograms per microliter that they determined was the threshold of significance. So I think that it is something that is detectable, that's found in the blood, and they kind of looked at it as a continuous variable to identify what the right threshold for high and low would be. So
basically, it's prognostic. It also predicts response to atezo. It seems
correct.
Like DFS to atezo. Why not validate this in the Pembro trial, which we know clearly showed the Pembro improved survival actually in RCC? I hate to give plugs to Tony Schwery, Tony, but what can we look at the same
yes.
thing in the Pembro trial?
I think that there are lots of wheels in motion to try to make that happen. I think it would be an excellent thing to be able to do, to really try to identify who are the individuals who absolutely need adjuvant therapy versus individuals who, their risk is much lower and they can get by without such treatment.
Petros, any reaction to this? I had my two questions.
Rana did a great job summarizing, and personally, I'm very excited to see biomarker data from large phase 3 trials. Every trial is very important, positive or negative. And as we all know, we can learn a lot from negative trials. When I saw the data, Rana, from the Emotion 010 trial, it reminded me of the InVigor trial that we published a few years ago with Joachim Bellmuth, right, and Tom Powles at adjuvant atezo did not prolong survival, DFS or OS, compared to observation in muscle-invasive bladder cancer. However, based on this negative trial, we learned a lot by measuring circulating tumor DNA, and there were some similar data at the time that circulating tumor DNA detectability was a negative prognostic biomarker versus DNA negative patients. Those who DNA positive, they do worse, higher chance of recurrence or death. But also there was a hypothesis generating there that in the IMvigor010 trial, that if you have positive ctDNA, you may have better outcomes with atezo versus observation. So that gave birth or genesis to the IMvigor011 trial that's now ongoing. And of course, we have the Tombola trial, the modern trial. So similar questions are being asked with ctDNA in urothelial carcinoma. So I think that story with KIM-1 reminded me that, and I want to see more data in the future to evaluate whether it's clinical useful, whether there's clinical utility or not with KIM-1. I think it's a great hypothesis generating data, as you pointed out, and looking forward to evaluate that biomarker more further in kidney cancer.
So Petros, that's a good segue to maybe something from bladder.
Absolutely. You know, there is so much to talk about. I'll try to keep it focused as possible. You know, in urothelial carcinoma, we have seen an evolution and rapid changes and a really explosion of new data sets. And we saw the same thing at ASCO 2024 annual meeting. I will probably focus a couple of highlights in the metastatic disease. And Rana, please comment, as I know you also have great insight. So a couple of abstracts to comment, Sadi and Rana. In the metastatic frontline setting, we saw two practice-changing trials at ESMO 2023 in Madrid. One of them was a V302 trial with pembrolizumab and enfortumab combination that was dramatically superior to platinum-based chemotherapy in terms of progression-free survival and overall survival. Hazard ratio was 0.45 for PFS and 0.47 for OS. And I think the data from EV302 immediately changed practice in the frontline setting, at least by the way the label of pembro-EV FDA approval did not specify the line of therapy, even if the data from EV302 and 103 was in the first line. So we know that pembro-EV is superior to cisplatin or carboplatin-based chemotherapy, and we know that that combination received FDA approval as of December 2023. The question is quality of life of those patients, because as we know, pembro-EV could cause toxicity, and we know that we need to be careful with those adjustments, halts, interruptions, especially with enfortumab. So we saw data by Dr. Gupta based on patient-reported outcomes collection in that study, and I think it's very important to see that PRO data that Dr. Gupta showed from EV302. It's interesting to note that in the chemotherapy control group, the compliance rate to fill out the PRO quality of life survey went down over time because people complete chemotherapy, so they have less visits, right, for treatment. So this led to some attrition in the PRO survey instrument in the chemotherapy control arm. The bottom line of this study, if we look specifically for the take-home messages, is that there was definitely, of course, the improvement in survival with pembro-EV, and that came without any deterioration in quality of life, which is encouraging. And if anything, there was signals that showing that maybe better pain control and change in worst pain data may favor pembro-EV because of the higher response rate and the longer progression-free survival. So overall, with the caveat of those attrition completion surveys in patients who had chemotherapy, I think the data, PRO data, I would say corroborate and complement the survival data and support use of pembrolizumab and enfortumab as a preferred, in my opinion, first-line regimen in metastatic urothelial carcinoma in patients, vast majority of patients who we think can tolerate EV. And
Rana,
I think is one of the take-home messages.
Yeah, Rana, I love stuff like that, right? PROs. I mean, it seems like a lot.
Yeah.
I think GU actually does more of these in PROs. I've seen this in kidney as well. I mean, reaction to this? I mean, I love when
I mean, I think the patient-reported outcomes are critically important to really try to understand what the patient experiences throughout the study, throughout any given study or any given regimen. But I think as a field, when I step back and I look at the way we do PROs, like we've got to figure out a way to do it better. A lot of times the instruments across studies are variable. The time points at which patients complete these instruments are variable. There's issues with missingness, especially as patients continue on treatment. So I think, I think it's really important for us to look at the patient experience, especially for a regimen like EV-Pembro, where the PFS is so long and patients can stay on therapy for quite some time, and even have therapy held and kind of still continue on treatment. So I think these data are important to understand, but I would kind of urge our field to, how can we better standardize these instruments and tools across studies to the same point that we standardize like the definition of response? Like it's, RECIST, and that's what it is, and everybody uses it, every study uses it, and it's validated. And not that I'm saying that we need one instrument, but I think we can do it better.
I do not like RECIST. I have no patience to write an editorial. How about, I have the title of the editorial I want to write. I just haven't had the time. But yeah, okay. Petros, you're on a roll. I think you had another one for bladder, you're going to say, right?
This is a great discussion, by the way. I agree with Rana that, standardizing as much as possible, PRO, quality of life data across trials, using the right instruments, as specific as possible, and of course, try to improve the compliance adherence to those surveys. I think can help us down the road. I think overall the data from EV-302, the quality of life data support the use of EV-Pembro with the limitations that we just discussed. Fitting that theme of dose intensity and dose adjustments of enfortumab vedotin, we saw some very interesting data, which I think are really practice informing, from Dr. Petrilak, looking at enfortumab vedotin dosing exposure and whether this dose intensity exposure has any impact on clinical outcomes in EV monotherapy trials. So EV-101, EV-201, and EV-301, these are 3 enfortumab vedotin monotherapy trials. And the question is, does the dose matter? And do the dose adjustments because of side effects matter in terms of outcomes with EV monotherapy? And someone could potentially extrapolate some of those data with Pembro EV combination. Although, as I mentioned, this is EV monotherapy data. The two take-home messages, and Rana, I want your opinion too, is the initial dose of EV seems to matter. So the starting dose of 1.25 mg per kg was associated with higher response rates. Response rate was 43% with that dose versus about 20% with lower dose. So the initial starting dose matters, and in those patients who are fit enough to tolerate that dose, I would reinforce my practice to use that dose initially for those who I think can tolerate it to 1.5 mg per kg. Of course, there can be exceptions in frail patients, so on and so forth. The second take-home point is that I think many of us recognize the need to dose adjust, either dose hold or dose reduce enfortumab, sometimes even discontinue enfortumab because of toxicity side effects, peripheral neuropathy, skin rash, fatigue, GI side effect, weight loss, hyperglycemia. There are different things that, may come up, and those dose adjustments are needed. And it's very important to educate the patients to not underreport so they can help us manage those, toxicities optimally and dose adjust if needed. And the bottom line is that those dose adjustments in those EV monotherapy trials did not compromise the outcomes with EV, just giving us some, support, reinforcing the practice that it's okay to recognize, report, and enfortumab vedotin related adverse events and adjust doses, reduction, holds, discontinuation if needed to manage those side effects.
Rana, reaction?
Yeah, I really love this abstract, and I can't wait to see a similar assessment come from the 302 data, particularly around dose intensity and even treatment-free survival. I think it was really critical to understand that actually upfront dose intensity does matter to get people into a response. And so I think that information is critically important. But also I thought what was really important to share was actually that subsequent dose modification did not necessarily compromise outcomes for individuals. So I think these are two really important concepts for treating clinicians that are using EV, that attempt to have patients start at the standardized dose, and once you see a response, obviously you're going to be assessing toxicity throughout the way, but you can peel back without necessarily compromising outcomes. And I think the data really highlighted that, and it's going to be important to see how that is going to be applicable for EV pembro, where patients are actually going, they stay on therapy for a long, long time.
Rana, what's the top couple of toxicities with EV that you'd like to warn people about?
I mean, the biggest ones are peripheral neuropathy, rash. There can be ocular disturbances, but I think the key one is the peripheral neuropathy that can build up over time. And peripheral neuropathy takes time to resolve. It tends to not necessarily be one of these side effects that you just, hold, day 8, and then it's going to be good by day 15. It just tends to not be that kind of way. So I think it's one of those side effects that you need to have a high index of suspicion for. Whatever can be done from an exercise, B12, to optimize patients during therapy and have a low threshold to make modifications if people are running into trouble, because it could become a problem if it's not assessed during treatment.
Petros, are you really raising your hand? I'm humbled.
First of all, I agree fully with Rana. I think these are great points. And I think all this together, as we discussed, can help inform practice. At the same time, one light bulb went on in my head that we have now efforts through cooperative groups to design future de-escalation trials. And as Rana pointed out, could we potentially think about future studies that either stop or reduce the dose of EV? So I think it will be this data support, the design and conduction of those future trials to evaluate the escalation of enfortumab over time.
This is great. Rana, your turn.
So, the next 2 abstracts, I guess I'm going to stick with kidney and then we can transition to prostate. But the other 2 abstracts to potentially highlight was the, updated final OS analysis from JAVELIN Renal 101. This was abstract 4508. Just to remind everyone, JAVELIN Renal 101 was a randomized phase 3 trial where patients with previously untreated advanced or metastatic clear cell RCC were randomized to receive either axitinib, avulimab, or sunitinib. And in prior presentations of this work, we saw that avulimab axitinib significantly improves progression-free survival compared to sunitinib, and actually ended up leading to an FDA approval of this agent. And so what we saw now that was presented by Dr. Motzer at ASCO 2024 was with a median follow-up of around 73 months, which is the longest follow-up for any of the ICI-TKI combinations, that, while there was an overall survival that favored avulimab axitinib, the OS was 44.8 months compared to 38.9 months. This did not actually reach statistical significance, a hazard ratio of 0.88. And so I think it was important to see this final OS data from, the JAVELIN Renal 101 study. I think it's important to level set in the context of the other ICI-TKI combinations where we did actually, in fact, see an overall survival benefit. So I think,
like which one?
From Checkmate 9ER, 426, the CLEAR study, PEM-AXI, Nivo-Cabo, PEMLEN, all demonstrated improvements across all 3 efficacy endpoints of response, PFS, OS in the intent to treat population, and are all FDA approved. So I think, one would be pretty hard pressed to use avulimab axitinib in the context of other IO-TKI combinations that have actually demonstrated an OS benefit.
Can I tell you something that that confuses me a little bit? And I hate to admit this on the air. I mean, I'm the host. I'm supposed to know everything, but hey, what the heck? I think my listeners know I know nothing at this point. But a lot of times when I see that, like the TKIs plus the IO combinations, I never know how the TKI and the specific ICI was selected. Like, for example, you mentioned, Cabo plus ICI. Then you've got here AXI plus ICI. But I never know why was it axitinib plus the avelumab? Why was it the Cabo plus the Pembro or Nivo, whatever it is? Like, is there actual mechanistic reason to combine this ICI with this TKI, or we've all done clinical trials, or this is a matter of funding, right? You were able to get the funding from these two companies and you do it. And the reason this matters is because, like you mentioned, the axitinib, no overall survival benefit, so it's likely going to be used less compared to other TKI, ICI, because there's overall survival benefit. But I just don't know, is there scientific rationale for this combination specifically? Why not axitinib plus pembro?
Well, axitinib plus pembro was evaluated in the
See,
KEYNOTE
that's why I don't know
46.
this stuff. Go ahead.
And avulimab, is a PD-L1 inhibitor as opposed to a PD-1 inhibitor. And, I have to say, nowhere in kidney cancer do we have a PD-L1 inhibitor that is approved. So this study looked at avulimab. There was, the Emotion 010 and Emotion 151 looked at atezolizumab plus bevacizumab. Those studies were negative. And so I do think that there is a difference between the PD-1 and the PD-L1 inhibitors. Now, why not, pembro cabo? Those are questions that are, I think, even beyond me and kind of probably are at the level of just, as you said, drug design, partnership, alliances, like,
well, it's a good point you bring up, the PD-1 versus PD-L1. I think that's a good point. Okay, next.
Next, who's on? Me?
Yeah, you said you got two. You said you
all
got
right.
Two.
The other two abstracts
and then
that
Petros
I want
is going to react to the second one.
Okay, all right. So the other two abstracts to highlight with regards to the kidney cancer studies is in essence abstract 4504, 4505. Both of those abstracts were from the IO TKI studies that we were just talking about. Tony presented biomarker data from the CLEAR trial. Brian Rini presented biomarker data from KEYNOTE 426. And, what was really, I've been talking about the Emotion 151 study. This was a study that was ultimately a negative trial of atezolizumab plus bevacizumab versus sunitinib in the frontline setting. But what was really wonderful about this trial is the robust biomarker work that was completed, both DNA, RNA, looking at trying to find predictors of response to treatment. And from the Emotion 151 study, there was transcriptomic signatures that were derived from the RNA-seq work that was done in the context of the studies. Patients were allocated into these 7 clusters, and there were, angiogenic enriched clusters and, T effector, inflamed clusters that seemed to predict response to atezo-bev versus sunitinib. But it's been really interesting in every setting where we have tried to apply those clusters to an external data set of a different clinical trial, such as the JAVELIN Renal 101, when it was applied to that data set. It was applied to 214, the Ipi-Nivo data set, though granted there was not that many patients that actually had tissue available for sequencing. And now it's applied to CLEAR and KEYNOTE 426. And generally what we see is that every way you splice the data, the IO-TKI combo or the IO combo does better than Sutent. The angiogenic enriched subgroups tend to have just better prognosis just in general, but it didn't seem that these signatures were in fact predictive. And both of these studies looked at PD-L1 status, and that was not predictive. And they looked at various gene mutations, VHL, SETD2, PBRM1. Those were not predictive. So I think, these abstracts were important because I think they continue to reinforce that we still have a long way to go with regards to predictive biomarkers and RCC. And it seems like these initial signatures are somewhat context dependent with regards to their utility in being able to actually truly be predictive.
Petros, look at you with the emojis. This I don't even know how to do that. But do you want to react to? It seems like you're happy with it based on the thumbs up.
Yeah, I was just giving thumbs up to Rana because she was able to articulate some complex concepts in very clear sentences, and I agree. And I think overall, it's important to, as I mentioned before, learn from every single trial. So I think I like the contextualization. So I was giving thumbs up.
Any other comments on these abstracts before you take another one?
I think that to Rana's point, I think it's important to learn from every single trial, and I like the trials, give us the final answer. So I think, for example, the avelumab trial, I like to see the final OS analysis. It's important for the companies to do that. I think give some closure and also help us put the data into context and perspective. So I applaud the authors for doing that. Even if avelumab did not meet OS, it's still important to know. And as I mentioned before, there's some very interesting biomarker data from the avelumab combination program, which I think generated some interesting hypotheses, looking at T-cell infiltrations and expression signatures that can be potentially be evaluated in other trials. So a lot of lessons learned, I think, again, as every trial, positive or negative. Back to your previous comment, Sadi, about the combination of a particular TKI with a particular immunotherapy agent. I think sometimes it's, of course, it should be based on mechanistic rationale, based on how preclinical data are being done. Sometimes it's also practicality. For example, if a company has two particular agents, logistically makes it easier to design a trial with that, or if two companies work together and they have already a framework of collaboration that can remove some logistical barriers, and sometimes that may drive which agents may be selected in phase 2 or phase 3 trials. That's a practical reality, in addition, of course, to the ideal mechanistic rationale based on preclinical data.
You have a bladder one for us before Rana gives us a couple of prostates?
I do. I can tell you a little bit about the CheckMate 901 trial. And that trial, I think it's important. It was overshadowed by the EV302 at the Presidential Symposium in Madrid of ESMO 2023, but still is an practice, changing trial. This is in cisplatin eligible patients in the frontline setting, patients who got randomized to GEM-CIS plus minus nivolumab. The addition of nivolumab was concurrently with GEM-CIS, and also continuation nivo maintenance up to 2 years unless there was interim progression or major toxicity. That phase 3 trial, the CheckMate 901, was presented before and published at the New England Journal of Medicine with Dr. van der Heijden from Netherlands and other colleagues. The randomized patients, about 300 patients, ballpark, in GEM-CIS or GEM-CIS nivo. The trial was designed before the data from JAVELIN Bladder 100 trial came about. So only about 20% of patients, about 1/5 in the chemotherapy control arm, got switch maintenance avelumab, and only 40% of patients got checkpoint inhibitor at any point of time before or after progression at the chemotherapy control arm. So these are a couple of caveats there that may affect the performance of the GEM-CIS alone control arm. Having said that, the trial met the endpoint of overall survival, hazard ratio 0.78, favoring GEM-CIS nivo, and also despite that the median PFS was about the same, there was a tail on the curve favoring nivolumab addition to GEM-CIS, and there was a benefit statistically significant for PFS as well, GEM-CIS nivo favored versus GEM-CIS. The response rate was also higher numerically with the GEM-CIS nivo versus GEM-CIS, and that difference in the response rate also correlated with less primary progression rate. So more patients stayed on treatment, less attrition if you add the checkpoint inhibitor upfront versus waiting until the maintenance phase. And that may be a potential reason why may people use the IO from the beginning, since we don't have a direct comparison between the CheckMate 901 and the JAVELIN. The theoretical advantage of having the IO upfront is to lose less patients, less attrition. The question was in that study, are there any patients that do exceedingly well with GEM-CIS nivo? And we saw that about 22% of patients had a complete response with GEM-CIS nivo. From all comers in the study, 22% had CR with GEM-CIS nivo, and the median duration of CR was approximately 3 years. So this 1/5 of patients with GEM-CIS nivo had CR, and the median duration of response was 37 months. Who are those patients? So there was some interesting discussion at the ASCO Annual Meeting about the patient subset who actually had complete response. And it's interesting that complete response subset was enriched in patients who had lymph node only metastasis. So if you think about the whole trial population, about 18% of patients had lymph node only disease, and this patient subset were overrepresented in the complete response subsets. If you look at lymph node only metastasis patients, the overall response rate was 82% with GEM-CIS nivo, and 63% were complete response rate. So very high response rate and complete response rate in lymph node-only disease. Obviously, that lymph node-only subset of patients represents a favorable prognostic group that do better compared to visceral metastasis or bone metastasis, regardless of treatment. We saw a little bit of a subset analysis from EV302 that those patients do better with EV pembro versus platinum gemcitabine. So I think, and we saw similar data at ASCO just a couple of weeks ago from the JAVELIN Bladder 100 trial. So my take-home point is, we know lymph node-only disease patients do better. It's a positive prognostic factor compared to visceral mets or bone mets. We do not know for sure which regimen is better, but every, I would say, treatment performs better. EV pembro, gemcitabine, or the JAVELIN in those lymph node-only patients. Questions being generated is, again, can you potentially get by and give a fixed duration of chemotherapy and then continue nivo alone? Would that translate in less toxicity over time, cost effectiveness, cost issues, treatment-free interval? Those questions are being generated and I think should potentially be studied in a more definitive prospective way. At this point of time, I think we see this better performance of lymph node-only patients across therapy regimens.
Reaction to that? I mean, I have my thoughts into how you escalate, but go ahead, Rana.
No, I mean, I think, you know, I do agree that the, you know, checkmate data were kind of overshadowed by EV302 and honestly continue to be, I think what's going to be really impactful with regards to the depth of response data and this kind of cohort of, you know, kind of extreme CRs is, I think we all want to try to understand durability. We've been able, you know, with prior platinum-based chemotherapy and bladder cancer, there seems to be a tail on the curve that has emerged, that we had seen in historic studies where people can really derive long-term disease durability. And I think it's going to be important to understand, are we going to be seeing that with EV pembro? You know, the response rate, the complete response rate was, you know, correct me if I'm wrong, Petros, close to 30% with EV pembro. So I think it's going to be important to understand the durability of these deep responses. And then also, like, in the people who like do progress, what are the patterns of progression? Can they be salvaged? Are they progressing in an oligometastatic fashion where you can still, you know, use metastasis-directed therapy? I think these are like the clinical questions that we really want to try to like tease out clinically.
Do you feel that, I mean, all of these questions are obviously valid. I just don't know how you answer them, to be honest, given the fact that I don't think you're going to have gemcitabine compared to pembro EV. I just don't think that trial's going to happen. So my question to you, do you think there's an opportunity here for liquid biopsies and ctDNA to look at separately at each study and see whether the depth of response for, you know, obviously resist, but maybe if you actually have more depth of response on the molecular level, there's an opportunity there to, I guess, either de-escalate or choose one regimen over another?
Yeah. No, I mean, I think there's not to say studies being designed now, but these like adaptive trials of escalating and de-escalating therapy around ctDNA, just given how impactful that has been in bladder cancer. You know, certainly want Petros to comment on this, but I think that certainly is going to be a wave of the future. You know, how can you adapt therapy with something beyond, like you said, you hate resist, with something beyond just imaging? Like, can there be a blood-based tool?
Oh, but the reason I hate resist is because it's arbitrary. I mean, come on, 19% versus 21%.
Correct.
I mean,
yes.
That's the reason. It's just because I feel it's completely arbitrary. I also don't feel it represents truthfully. I mean, somebody sat there and says, we're going to agree over 20% is X, Y, and yeah, it just seems ctDNA is just different.
Yeah.
Yeah. Okay. Prostate, or Petros, you still got something else? You had something else?
No, this is a great discussion. I think, as you mentioned, you know, it's impossible to do every single trial, you know, comparing all regimens to each other. And you know, at some point, as you said, we have to take into account all the data sets and individualize in particular patients to make recommendations. I think the future is even brighter. The present is bright, but the future will be brighter. Number one, because we're going to even try newer agents and potential triplets, try to build upon pembro EV down the road, as we mentioned before, maybe de-escalation trials, looking at potential less toxicity, less cost. At the same time, I think the advent of biomarkers, specifically circulating tumor DNA, is very promising. We still have to figure out the clinical utility that we're discussing before, how to optimally use ctDNA in what setting, in which time point, which assay, how does this going to impact management and eventually outcomes. These are still open questions and we need to answer them prospectively in clinical trials. There's examples of ctDNA driven trials in the adjuvant setting. For example, the IMvigor011, the Modern trial, and the Ebola trial. And of course, the other big question is access to those therapies. And, I always remind myself that, pembro-EV is great data, impressive, fantastic, but as of today, to my knowledge, is available only in the US. So the rest of the world doesn't have access to it. So that's an important consideration as we think about an equitable healthcare delivery globally.
Rana, we can't forget about prostate.
No, we can't. How is this possible that we're talking about?
We've got me and Petros here. You can't forget about prostate. Come on.
All right. Well, here we go. So I feel like in GU we had gotten spoiled with like one plenary after another at every single one of these annual meetings. So I think to keep on the same note of ctDNA, I want to highlight data from the PSMAfore study, which looked at baseline ctDNA levels and conversion rates and outcomes for patients receiving lutetium therapy. So just to level set, the PSMAfore study was a study that was conducted in patients with metastatic CRPC that had progressed on a prior RP, that were taxane naive, but did have PSMA positive disease based on gallium 11 PET imaging. And patients were randomized 1-to-1 to receive lutetium given IV every 6 weeks for 6 doses, or the RP switch, as determined by the clinical investigator, whether that be abiraterone or enzalutamide. The primary endpoint was rPFS, and the study did allow for crossover with greater than 85% of patients actually crossing over to receive lutetium. And so in this exploratory analysis, they actually looked at, baseline ctDNA levels and early ctDNA dynamics and correlated that with outcomes. And I think the first thing was that ctDNA, the cell fraction, is actually prognostic in prostate cancer. So independent of the arms, you have high levels, you do worse, you have low levels, you do better. Now, when you look at the application of that biomarker in the patients who actually got lutetium and in the patients who actually got an ARPI, again, it still stands true. Whether you got an ARPI or whether you got lutetium, baseline ctDNA level was prognostic. Higher levels doing worse, lower levels doing better. What was also really interesting that they did was looked at early ctDNA clearance and correlated that with rPFS. And the group of patients that seemed to do the best were the people that were non-detectable at baseline and stayed non-detectable, or those who were detectable and actually converted early on to become non-detectable. Those individuals seem to have the best outcomes in both groups, like the lutetium-treated patients and the RP-treated patients. Now, of course, the PFS was much longer in the lutetium-treated patients than the RP-treated patients, but that trend was maintained. The people who seemed to do the worst were people who actually started out having detectable levels and remained as having detectable levels with either no increase or no decrease in their levels, like, when you actually track the levels early on. So those people seem to do the worst. There was additional analyses that looked at AR amplifications, that looked at TP53 mutations, and also looked at chromosome, chromosome 8 alterations, kind of assessing MYC amplification, and the presence of AR amps, TP53, and 8q amplifications were basically associated with worse outcomes. And they did this for rPFS, and then they did it for RECIST for the people who are evaluable, and they did it for PSA50, and it seemed to be concordant across these different biomarkers. So it was really interesting to see this, because getting serial PSMA PET imaging, like, we don't know what to do with that in prostate cancer. It's not really helpful. We don't have criteria to determine response or progression. And so thinking about these biomarkers is important.
Any thoughts on that, Petros?
I agree fully that the biomarker work is essential, and I think we did not have much data. Again, looking at the clinical utility of ctDNA across GU cancers. So I think having data is important. Obviously, the prognostic question is the lower bar, right? And as Rana pointed out, higher ctDNA, worse prognosis. It's a thing that we see, I think, across tumor types now, just generating across tumor cancers data about the prognostic value of ctDNA. The next step in the higher bar is the predictive question, whether higher ctDNA might predict benefit from a particular individual therapy or a combination. And I think this is the next step. I think this is where we need to go. And also, the dynamic nature of ctDNA, as Rana mentioned, you can measure it over time serially, and that actually can give us some insights about the clearance of ctDNA that seems to be prognostic by itself. The big question is, how can we leverage that? How can we design trials to evaluate ctDNA and see if it can give us some lead time before the scans get worse, and whether that lead time is meaningful or not. For example, if you switch therapy at that time versus waiting for scans to get worse, does it make a difference or not? We do not know the answer to that question, but these are some of the questions we try to answer in the future. And they were actually, in that context, I will quickly comment that it was an interesting abstract at ASCO Annual Meeting from the Keynote 361 trial, metastatic urothelial carcinoma, looking at chemotherapy versus pembrolizumab versus chemo plus pembro, and that data did not show survival benefit with chemo pembro versus chemo. So the addition of pembro to chemotherapy did not prolong survival. But there were some interesting data at ASCO Annual Meeting 2 weeks ago, looking at ctDNA clearance and dynamics and kinetics over time that are not relevant to practice right now, but are very interesting and generating hypotheses about exactly that question. How can we understand better the ctDNA kinetics? How can we use this data for future trial designs?
Rana, let's take another one for prostate. The one plea I have is whatever biomarker that you're going to look at for prostate and whatever the ctDNA is going to find or show must be better than PSA. I mean, right? I mean, we have a biomarker.
Absolutely.
We have a biomarker in prostate. And my skepticism is always, okay, it's great as long as you show me that this is going to be better than because PSA is pretty damn cheap. And so it has to be, if I'm going to be willing to tolerate the cost of an expensive biomarker, it has to be better than PSA. So looking forward to seeing that.
No, I completely agree. See, that's the crux in prostate cancer, right? Like when people get into MCRPC,
right.
I'm not making treatment decisions based off of PSA going up. Right. You know what I mean? I don't have enough options if I'm making treatment decisions based off PSA rise alone, and patients aren't actually experiencing any, that's a biomarker. It's not like, a clinical phenomenon.
It does predict that at some point, like you could have the biomarker going up before radiographic progression, but there's no question it's going to be followed by radiographic progression. It might start with PSA. There's a lead time, obviously.
Right.
Anything else earth-shattering? I know that Petros had warned me that he cannot really stay longer.
Yes. There's a lot going on prostate, but I actually want to highlight a penile cancer trial, and we can end with this if it's okay with you. I was going to talk about ARV-766, but I know we've got a time lag. So this was a wonderful study called Hercules. I love the name. That was conducted by the LACOG group. It basically was a study of first-line pembrolizumab with platinum-based chemotherapy for patients with penile cancer. It was a single-arm, open-label phase 2 study that was enrolled across Brazil. This is an incredibly difficult patient population to enroll. And quite honestly, there's just not a lot of clinical trials for individuals with penile cancer. Patients basically received triple therapy with a platinum, whether it be cis or carbo with 5-FU plus pembrolizumab, and then received maintenance pembrolizumab with a primary endpoint of objective response. And the objective response rate with this combination was close to 40%, 39.4%. And so I think it was really important.
These are metastatic patients.
These are metastatic patients. So I think this was a really important study. It's a rare subgroup. It was conducted through the cooperative group mechanism, essentially in Brazil. And, it's unlikely that a phase 3 trial would ever be conducted in this setting. So I think these sorts of studies can certainly be practice informing and potentially practice changing for these rare subgroups.
Do you usually do adjuvant therapy for penile cancers?
Yeah, sometimes you do adjuvant therapy
Like,
for those patients.
I ask because would this mean that you would use this regimen in the adjuvant setting? Like, I guess, is there enough information? Maybe the company might go for registration or submit for approval or something. I don't know.
Yeah, I think time will tell, but I think this was an important study to highlight.
Petros, we cannot. Is there anything earth-shattering that we missed? Because, you know, I mean, I have very critical. You know, the critics are out there.
You know, I like what we have discussed today, and I kudos again to the LACO group for doing this study. I really enjoyed seeing the presentation by Dr. Malouf and his colleagues. It's great to see that, you know, that diversity, right? And inclusion of studies, you know, come, you know, from different parts of the world. I will just end maybe by commenting by a little bit about probably the most discussed topic in bladder cancer, at least, or urothelial carcinoma, let's say, at ASCO, was based on data that were not presented. And this is the press release of the TROPIC-04 trial. I think we cannot say much because we have not seen the data yet. We have seen only a press release, but I want to put this press release in context of the SOAR-01 neoadjuvant trial that Dr. Antonio Scigliola from Milan, Italy presented. The SOAR-01 trial looked at neoadjuvant sacituzumab govitecan, SG, alone monotherapy in patients who are undergoing radical cystectomy for muscle-invasive localized bladder cancer. Long story short, the signal is that if you use sacituzumab govitecan, make sure you use growth factor GCSF as primary prophylaxis. That's important because there were some documented grade 5 neutropenic events in the press release at least, and also in the Italian study that Dr. Scigliola presented. So they amended the protocol to actually do some interventions. They lower the dose, they adjust eligibility criteria, and they use growth factor upfront. And I think that's an important point. If for colleagues who practice out there, sacituzumab govitecan has an accelerated approval in advanced urothelial carcinoma after chemotherapy, after checkpoint inhibition. It may be used after enfortumab or dafitinib, whatever the sequence is. If you use sacituzumab govitecan, use it with growth factor as primary prophylaxis from the beginning.
This was really amazing, and you know, I can't really thank you enough. I'd like just for Petros to comment how come Greece did not make it to the Euro Cup.
I can tell you, you know, Greece came very close, and they lost, I think, in the penalty kicks in the qualifiers. Having said that, I think we're seeing a fantastic Euro 2024, and one day, Chadi and Rana, hopefully we can watch together the Euro, or maybe the World Cup in the United States coming up.
I still remember, Petros, when Greece won Euro Cup. I was very happy because they were the underdogs, and I was cheering for them. It was in Greece.
It was actually a great memory. 2004, it was in Portugal. I think,
Portugal.
It was in Portugal, and Greece beat Portugal in the final game. So I always, you know, enjoy, you know, watching soccer with my friends and colleagues. And these are amazing memories. I can tell you, I have videos. The whole country went to party for days after Greece won the Euro Cup because it was insane.
I mean, the whole country is usually partying every day, every night anyway. So just like, you know, basically Petros Grivas beating Pedro Barata. I mean, that's what happened, you know.
I just texted my friend Pedro because Portugal is doing very well in the current Euro 2024. So
I'm going to text him because I don't want Portugal to win. So I'll text him probably. I congratulate him about this, but then I will tell him. I predict France is going to win. We'll see what happens.
Let's see what happens. It's a great tournament.
So Rana, make sure you watch. All right. Well.
Oh yeah, actually, it was really funny. I think there was like a big screen soccer game playing, like, what is it, Saturday afternoon or something like that. Everybody was watching the soccer game. So
during ASCO was Borussia Dortmund.
During ASCO, like
versus
it was
Real Madrid. It was the Champions Leagues. But yes, hopefully we'll watch World Cup together when it comes to the US in a couple of years. All right.
And Olympic Games are coming too, Sadi and Rena. So we're excited about Olympic Games in a few weeks.
Yeah, well, I'm very thankful. You always give Healthcare Unfiltered and the listeners. Trust me, this effort does not go unnoticed. And believe me, it is helping a lot of folks who try to stay up to date, because we keep it focused, we keep it, and we have some fun with it. So thank you so much for doing this.
Of course. Thank you.